Hello, everyone. I'm Eric Petersen. I'm the program director and founding director of the Arizona Program for Exploration Medicine and Surgery. It's housed at the University of Arizona at Phoenix. I'm a trauma critical care surgeon there, and I also did my training at the UTMB Aerospace Medicine program. I'm kind of talking today about the need for formal space surgery training and our APEX fellowship to kind of introduce it. I'm supposed to keep this slide up for 7 seconds, I'm told. So I have no conflicts of interest. I only have 3 kind of major goals for you all today in this quick presentation. One's to kind of talk about the need for space surgery. You're going to hear that a lot throughout these presentations. Also talk about the need for aerospace training for surgeons, and then kind of highlight what our APEX fellowship is and where it's going. And I just want to take a quick parallel here. You know, just a little over 100 years ago, we didn't have heavier-than aircraft, and nowadays we're flying over 4 billion passengers per year. And one of the things our fellows rotate through MEDAIR, which is the major responder to in-flight medical emergencies. And one of the things that we've learned is that in-flight events are just normal illnesses now that just happen to happen in flight. And so, you know, we're kind of in this newer age of commercial space. And I just can imagine where we're going to be in the next 100 years. And as that progresses, will our risks of surgery start to mirror the background population as well? And here are kind of some of the pillars that I've put together for surgery in space. One is the risk of surgery. How do you communicate and understand that? Another is the technology, something SAGES is very well aligned with, mass power volume. And then, of course, you're in a different environment and you're treating a slightly different patient as well, so things that you have to learn. One of the biggest things is communicating risks. The commercial space industry is an engineering world, and so you have to kind of learn to talk their language and communicate with them and talk about risk in the greater trade space with those engineers. And this is kind of an example of that recently published update to the NASA Human System Risk Management process. This is a likelihood by consequence table if you haven't seen one before. Ideally, you like to be in the low likelihood and low consequence. But you know, when you start thinking about surgery, that could be a higher likelihood and a very high consequence if it's a life-threatening infection that develops from your emergency surgery. So the table on the left side of the screen kind of gives you a rough idea how you can change likelihood. So if you want to get out of the red, which is ideal, you'd have a likelihood less than about 0.1%. So you can change this by screening, prophylactic surgeries, things like that. But the consequence is what we're really worried about with surgery, right? So on the lower side of consequence, a level 1 would be something like temporary discomfort. You know, you have a bruise from an impact, but it's only causing temporary discomfort. It doesn't limit any of the crew's functionality or their mission importance, all the way up to a consequence of 5, where that could be loss of crew life and you know, early return of your vehicle, so loss of the mission as well. And that's where I think surgery is trying to buy down some of that risk by bringing down the consequences of developing appendicitis or cholecystitis or other disease processes treated surgically. And so as we start to predict the future here, you know, 50, 100 years when maybe we're flying more of the general population, you can start using background population data to try to estimate your risk. And when we looked at the healthcare utilization project to start saying, hey, what medical problems are people coming to the emergency department with? This is kind of non-specific. We didn't go down to ICD-10 codes yet, but you can start seeing that, you know, they're in that risk likelihood of maybe 2, 3, 3, 4. Short durations is something we modeled off the VAST. I don't know if you know VAST Aerospace yet, but they're a company trying to do orbital platforms for commercial spaceflight. But a 30-day, maybe 4 to 6 person mission. Okay, so you'll have a small medical kit. Low likelihood, but you can treat most of those issues. As you start looking at the theoretical 100-day, 500-person, you know, big deep space mission that SpaceX is potentially proposing, you're going to have a much bigger medical kit. Now, what surgeries do people present with, or you know, inpatient surgeries do they undergo? Again, if you look at short duration missions, you probably don't really need to buy down further risk because it's less than that kind of 0.1% risk profile. But when you do start looking at deep space mission profiles, that's when you do have to say, hey, we have to make a cognitive shift and say that we do want to incorporate at least basic surgical principles in those missions. You're seeing a likelihood of level 5 here with a lot of those surgeries. So how do we bring those down? And of course, I just wanted to highlight some of the things that, as a trauma and general surgeon, I'm interested in. So that kind of highlights the risk and communication stuff. And we teach our fellows to start understanding that so that they can interact and start managing the trade space discussions with the engineers. The technology side. Well, mass, power, volume, and cost. My fellow used to make fun of me all the time because she said she's going to get a tattoo of mass, power, volumes because I talk about it so much. But on average, about 1 to 2% of a payload of a rocket is the actual payload. And if you're going to deep space, which is kind of where we're thinking we need to go with surgery, that's even a smaller fraction of that. So you can imagine how sensitive the engineers are when you say, I want to bring up a 1-ton robot. Power, until we figure out better ways to do fission or fusion in deep space, we're limited by solar generation. And the deeper you go away from the sun, the less power you get. The volume of a standard ISS rack is about 73 cubic feet. You can kind of see the on-orbit medical system here. It's about an industrial refrigerator size, but about half of that volume is dedicated to checking your environment, checking the water systems, and not actually delivering medical care. And then it's also very expensive to get to orbit, even though reusable rocketry has really brought that down by a factor of 10, and maybe even another factor of 10 in the near future if things like Starship come online. It is still very costly. This is what we dream of, right? I feel like if you Google surgery in space, this is like one of the first images that comes up, and man, I would love to have something like that. You see a nice robot, a separate module for all of this to happen, and maybe early Space Station Freedom designs were similar to this, but it's not really the reality anymore. Here we go. So I wanted to highlight virtual incision. We have some of their speakers here and representatives here with them. That's a great step in the right direction, right? Lower mass, lower volume. That's awesome. And this is a little bit outdated, but this is kind of what they had for a while on the International Space Station for the emergency surgery subpack. So you can kind of assume that you're probably not doing a lot of advanced surgeries with that emergency surgery subpack there. And then, of course, you have the changing environment and the spaceflight physiology. Of course, you're in the microgravity environment. You don't have buoyancy. You have to restrain your patients. In the parabolic flight campaigns in the 1990s, they did a lot of tests on this. They looked at doing surgery on pigs and tool management and where they're going to place everything, and kind of discovered that as long as you restrain yourself, your patient, the tools, and you have a good system for that, it's very doable to do surgery in space flight, or at least in the microgravity environment. But of course, you also have 10 times the particulate matter and potentially increased pathogenic bacteria around. So you have to have some way to have a barrier to the environment. And again, something that SAGES is interested in, minimally invasive. Can you use the body as a natural barrier? And of course, you're treating a slightly different patient as well. If you're looking at well-trained NASA astronauts who work out 2 hours a day, 6 days a week, you might be able to maintain a lot of their muscle mass, their bone density, but that might not. Did that microphone just go out? There we go. But if you're looking at commercial spaceflight, that might not be something you can be able to maintain. And so a commercial astronaut arriving to the deep space platform might be a little bit more deconditioned, have different fluid shifts, volumes of different distribution for different medications. And even if you're thinking, maybe I'd treat appendicitis pharmacologically, is that medication still going to be viable in the deep space environment after spending 2 to 3 years in the radiation environment? It's one of the big questions outstanding in the pharmacologic world for space medicine. And so, I think it's kind of fun to highlight all these challenges to space surgery, but one of the biggest issues here is that black box in the middle that kind of unites them all, and it's the provider's surgical training. In 2008, the Aerospace Medical Association put forth a consensus document that talked about how that's going to be the limiting factor about carrying out surgery in deep space. Do you take somebody who's never had surgery training and then rapidly teach them to do a procedure? Can you even do that? Maybe in the modern era of artificial intelligence you can. Or are you dedicated to taking a surgeon in deep space? Those are some of the big questions you have to figure out. But a creative surgeon who's able to adapt with the technology that they have is going to probably be the most important factor. And so even through my training, I noticed a kind of an evolution, and it kind of goes in a pendulum. But when I was going through, I was often told that surgeons were only really needed for, expert consultation. And I was multiply told surgery in space will never happen. And then there's been a kind of a huge swift back that said, well, maybe we just need surgeons just for launch and landing. And now a lot of these commercial platforms are saying, well, will we need to do surgery based on our mission profiles? we should start talking to surgeons who understand the language so that we can build the right tools for the right time, the right patient. And that's kind of where our fellowship comes in. It's the Arizona Program for Exploration Medicine and Surgery. We house it at the University of Arizona College of Medicine in Phoenix. Our mission is to address the challenges of deep space medical and surgical care and adapt the solutions to try to help everyone. And if there's an organization that kind of rings similar to that, I think of SAGES as well. But it was designed when I was actually at SpaceX with one of the now astronauts, because we were trying to brainstorm how are we going to take care of people in deep space. So it's a tri-party agreement between UA, College of Medicine Phoenix, Banner University, who's my employer, and SpaceX. And our first fellows there is Dr. Kaylee Sabinow, and she's actually getting hired part-time at SpaceX right now, which is pretty exciting that we are going to have a surgeon at a commercial space provider. But here's the program outline. We have kind of different pillars, academics, clinical, research. This is kind of the highlights of the clinical experience. We give them hyperbaric medicine, ultrasound experience, because that's their only imaging modality in deep space as of right now. We actually get them even working with the trauma critical care nurses at bedside, because not a lot of people go through and learn those bedside procedures. And if you're going to be a deep space provider, you have to be a well-rounded provider as well. And then you get graded austere kind of exposures with Flight for Life, EMS, and then we also partner with the Billings Clinic on Montana to get more critical access exposure, where if a general surgeon is going to be our fellow, we might teach them more neurosurgery, orthopedic surgery, anesthesia. Our first fellow is ENT, so she got a lot more trauma and emergency general surgery exposure. Our education mirrors that's from the American Board of Preventive Medicine and Aerospace. We basically took their curriculum and their resources and built out our own curriculum to model that, so there's a common language that they can be expected to graduate with and talk with the other aerospace trained individuals. And of course, we are partnered with the Biosphere 2 down in Tucson. They're building out the space analog for Moon and Mars missions. That's called SAM. You see a picture of that. It's from the old test module of the original Biosphere. And that's where we're doing building out the medical supply and surgical supply for that, so we can start doing some simulation practice there as well. Our vision is we're building out our website. You can check out apexmedicineandsurgery.com. Hopefully it'll be a good educational resource if you want to start diving into some of this. We're also building annual introductory courses where people could sign up and come out and down to Biosphere 2 and learn the basics of aerospace medicine. We're building out our simulation and research arms and building research ties with the capstone engineering teams, and hopefully to sponsor an engineering project in the world of space surgery every year, and then hopefully to build out other relationships with partners like you all. Thank you very much for your time, and we answer questions later.